So, think Karnakaran sir, good evening, sir. Thank you for joining us. I think Sridhar sir, welcome, sir. Good evening, sir. So, friends, warm welcome to this Friday's PG Clinics. We have a very eminent faculty. First of all, officially, I congratulate our faculty, Professor Jailal sir, was being selected as International Secretary General for the Commonwealth Medical Association. For friends, you should be aware, Commonwealth Medical Association directly reports to the His Majesty Charles II. So, sir reports to His Majesty Charles II directly. And I guess it is having a personal office at the Westminster directly, Barlow's Hall. And it governs 56 countries. And the total population, sir, is going to cover is close to 2.5 billion population. And it is one of the most powerful association next to World Medical Association. Am I right, sir?
Yes, sir. Yeah.
So, and then lot of social activities like health for downtrodden, the third world countries. The scope is humongous, and very happy. Think we have our person there, and proud of you, sir. And let us move to the class. I still thank you. In spite of all these achievements, you still make time. This is an important lesson for us. So teaching still holds the heart of you. I'm very, very thankful to you, sir. And we have three eminent faculty. Professor Sridhar sir, Professor and Head of the Department from Apollo Institute of Medical Sciences and Research, Hyderabad. Very eminent teacher and has been associated with PG clinics for many years. And sir has been almost watching every class from the time of its inception. We have Professor Ganga Lakshmi ma'am, again kindly contributed by Professor Vasan, whom we met recently, few days before in Kanyakumari for the PG clinics hosted by the Kanyakumari Government Medical College during the Pink October celebrations. Thank you, madam. Thank you for joining us today. Madam is a professor and head of the department from Government Sivagangai Medical College. And our own faculty, like she's been there with us many times. And also I should tell, I pulled her up in the last moment. Madam was kind enough to accept the invitation. Professor Anandi ma'am. Anandi ma'am is a professor of surgery at Government Stanley Medical College and a very eminent teacher. Still reads every day 2 hours on academics. So I don't know, I'm not able to replicate madam. She is still whatever, how much ever cases or whatever be the list, madam has the habit of updating herself. Karnakaran sir, other seniors, thank you, sir. We have Professor Ajay Khanna sir. Ajay Khanna sir is the professor of surgery from Banaras University. I don't think he has ever missed a session for the time of inception. So two patients have been contributed by one from Thuthukudi Medical College, Dr. Kalayarasan, again by Professor Vasan. And the other one is by Professor Sridhar sir from Apollo Institute of Medical Sciences and Research. So we'll have the first presentation from Thuthukudi, Dr. Kalayarasan. Please introduce yourself, your unit assistant professors, chief, HOD, and start your presentation. Kana, you are in mute mode, ma.
Sorry, sir.
Yes, please share your screen, PowerPoint. You have to adjust your tab little bit, ma. You are looking on the sides.
Oh, move little away from the screen.
Kalai, you have rotated. Yes, you are okay now. Yeah, you are perfect, Kana. Straight away, thank you, Slide. Okay. Good luck to you. Faculty, please take over.
Good evening, sir, ma'am. Myself, Dr. Kalayarasan, final year surgery PG from Government Thuthukudi Medical College. Dr. Vasan, sir, is our HOD and Chief of Unit 1. Under his guidance and under the guidance of our Assistant Professor, Dr. Meena Ranjani ma'am and Dr. Dalton, sir, I'm going to present in this PG clinics a case of carcinoma. A 62-year-old female from Thuthukudi, housewife, came to surgery OPD with complaints of ulcer in the tongue for the past 6 months and complaints of swelling in the left side of the neck past 3 months. Presently, patient was apparently normal before 6 months. Later, she developed ulcer on the left side of the tongue, which was initially small in size, slowly progressed to size. Associated with pain during chewing. It is dull aching and not aching. No history of bleeding. There was a complete swelling over the left side of the neck, 3 months, which was onset in progressive in nature, not associated with pain. History of excessive salivation is there. History of difficulty in chewing and speech due to pain movement of the tongue is there. No history of trauma. No history of use of gin. No history of loss of weight or appetite. No history of breathlessness. No history of difficulty swallowing. No history of halitosis. No signs and symptoms of Horner syndrome. The patient has no known comorbidities, no significant surgical history, no history of any drug or no history of any interventions in the past. Patient takes mixed diet, normal sleep pattern, normal bowel and bladder habits, not an alcohol smoker, tobacco and beet fever, attending supposed to back. There is no history also. So. In general examination, patient.
Can we move on with the history first?
Ma'am?
Can we start with the history first? Can we go on to the first slide? So patient has a complaint of an ulcer in the tongue. So what are the possibilities of this ulcer? What do you think of?
Be in this age group, her age is 62 years. In this age group, this may be due to cancer or trauma.
Medicine is not audible.
No, ma'am.
One ID, Mr. Ellen, please mute yourself. We are not able to. Oh, somebody is there who is disturbing us. Ellen is ID. Thank you. Right, Kalis, now continue. Tell me what are the possible causes you think of for an ulcer in the tongue?
In older age group, the ulcer may be due to
Carcinoma. Is it audible?
Yes, ma'am. Audible, ma'am.
Okay.
Audible. Yes, ma'am.
Other causes of an ulcer?
Traumatic ulcer, syphilitic ulcer, herpetic ulcer, and
what are the other causes of ulcer in the tongue?
Traumatic, syphilitic, herpetic ulcer. Is it audible?
So the commonest ulcers which we see is going to be the yeah, I'm able to hear you. It's an aphthous ulcer, which is the commonest one, but that would be the commonest type of ulcer which you see in a day-to-day practice, right? But an elderly person who's coming with an ulcer, you think in terms of a malignancy, and this patient has got a swelling in the left side of the neck. So coming on to the next slide. What do you mean by quick chewing?
Pain during chewing. This is
okay. Where is the pain?
Ma'am, in the tongue, ma'am, over the ulcer area, there is pain during chewing due to ear.
Yes.
due to irritation of
Due to
the ulcer, nerve endings, and there may
okay.
be infection in the ulcer that will lead to the pain.
Is the radiating anywhere? Where all you can expect the pain to get radiated?
Ma'am, it is expected to radiate to the ear, ma'am. Due to involvement of the lingual nerve, it will be referred to ear via the auriculotemporal nerve.
Okay.
In this patient, there is no radiating pain to the ear, ma'am. There is no history of ear pain.
Okay. So which is the afferent and which is the efferent? No, which is
The audio is breaking.
afferent and which is the efferent one and which is the ganglion in between?
Ma'am, a Gazerian ganglion.
No, madam is asking you
It
what is a
is aortic ganglion.
afferent nerve and efferent, because the referred pain is one, afferent and efferent are different.
Okay.
So you must tell what is the afferent nerve, from where the information is going, then what ganglion and what is
Okay.
coming out.
Okay. From the lingual nerve, it goes and the aortic ganglion, and it is referred to auriculo via the auriculo.
What are the other nerves supplying the ear?
Okay, if it's a patient.
What are the other nerve supply of the ear? What are the other nerves which supplies?
Okay, if the lesion is going to be, where is the lesion to have involve the lingual nerve?
Sir,
In the tongue, where is the lesion present?
lateral, in this patient, it is present over the left lateral border of the tongue, ma'am. If it is involved floor of the
okay, if the lesion is if the lesion is in the posterior third of the tongue, then will there be a ear pain?
Yes, ma'am. There may be pain due to obstruction of the eustachian.
Do you think the posterior one that is supplied by the lingual nerve?
Sir, no, sir. It is not supplied by the lingual nerve. When the
What is the nerve which is related with the posterior third?
takes mixed diet,
What is the nerve which is relation with posterior
normal
third?
bowel and bladder habits, not an alcohol, tobacco and beet fever, attending supposed to back. There is no
Voice is coming.
also, sir. Audio.
Somebody is presenting something else.
General examination. Patient.
Kanagavel, sir.
Who is presenting?
Madam, Kalayarasan, madam.
Kalayarasan is presenting.
Rajiv sir, good evening, sir.
Good evening, sir.
Anna sir, good evening. Madam again got dropped, I think. Please proceed, madam.
Am I audible?
You are fine, madam. You are fine, madam. Perfectly fine.
Okay.
Please go ahead, madam. Let madam come.
Okay, Kanagavel. Right. Kalayarasan, the
Yes,
question was, if the posterior third of the tongue is involved, will there be a spread to the ear disease? Will there be a referred pain to the ear?
No, ma'am. It is not supplied by lingual nerve, ma'am.
If so, through what nerve and what? Okay, in that case, what is the nerve? What is the afferent and what is the efferent pathway?
Ma'am,
It is
vagus.
through the glossopharyngeal nerve. Okay. Glossopharyngeal nerve.
Okay.
Will be the afferent and it will be reaching the tympanic plexus. Thereby, it will be involving the inner ear and the middle ear part. That is the pain is getting localized. Okay. Kala, you said there is an excessive salivation. What is the reason for this excessive salivation?
Due to irritation of the minor salivary glands, there will be production of excessive saliva, and the patient will have pain during swallowing, and the swallowing effect will be poor. So there will be pooling of saliva that That is the reason for excessive salivation.
Actually, there is both
Okay.
excessive salivation and decreased swallowing.
Yes, sir. Yes, sir.
It's both.
Yes, sir.
Yes.
So it is mainly because of the floor of the mouth. Sometimes it might get involved. That might be the reason. Not only because of the irritation. One, because of the pain, the patient will be having difficulty in the swallowing. The other might be the patient might be having a tongue which might be fixed to the floor of the mouth. That is a ankyloglossia. So the patient will be having difficulty to swallow. Okay. Can we move on to the next slide? Kalerasan. Next slide. First one. Kalerasan.
He is having some problem, madam.
He is having a problem. Okay.
I think his
நான்
connectivity is having some issue.
நான் தான் கேட்க மாட்டேங்கிறேன்.
Kalerasan?
Okay.
We'll give 1 or 2 minutes, ma'am. Otherwise, we'll ask. Sohail is also with us already. We can take his case first.
Okay. Right.
His PowerPoint is still there, seen. Kalerasan?
Sir, we'll go ahead with Sohail presentation, sir.
Ma'am, we'll go to the next case, sir. No, sir, we have to first unshare this. Let me see. 1 second.
You can do it, sir.
I will try, sir. I will try. Sohail? Dr. Sohail?
I'll call him.
Sohail, you can start sharing your PowerPoint and start your presentation, Dr. Sohail. Then once he comes, we can go for this discussion a little later. Good luck to you. Make it full screen, ma.
Hello, sir.
Are you okay, Kalerasan?
Hi, sir. The
You
audio.
take, you take time. You take time. Let him present the varicose veins. Later.
Okay, so Kalai, you please wait because we have started the presentation of Dr.
Well, you
Sohail.
check
Then you can
what are
present
the
after he
issues with
completes.
your system. You check.
Okay, Dr. Sohail, please start your presentation. Your slides are seen well, ma. Please start your presentation. Kana, you have to remove your headset. We are unable to hear you at all.
Hello, sir. Hello, sir. Can you hear me, sir?
Yes.
Yes.
Talk loudly.
Yes, sir. Yes, sir. Good evening, everyone. I'm Dr. Sohail, General Surgery postgraduate from Apollo Medical College. I'll be doing a case presentation on varicose veins under the guidance of Dr. L. Sridhar, Professor and HOD, and Dr. Faz Hussain, who is an associate professor under the guidance. A 48-year-old female patient resident of Sangareddy, Telangana, teacher by occupation, presented to surgical OPD with chief complaints of dilated veins along the inner aspect of left lower limb since 5 years, and patient also has pain in the left lower limb for the last 1 year. The patient was apparently asymptomatic 5 years back. Then she noticed multiple dilated veins over the inner aspect of the left leg, initially above the ankle, and then progressed to the left leg and thigh. These swellings become more prominent on prolonged standing and reduced on lying down. There is a history of association of dull aching pain in the left lower limb since 1 year, and the pain gets aggravated on prolonged standing and walking, and it is relieved on rest. There is no history of pain and swelling in the calf, which is associated with the fever in the past. No history of any night cramps, no history of any intermittent claudication. There's no history of any trauma. There's no history of any itching over the leg or an ankle. There's no history of any pigmentation of the skin of the leg. There's no history of any ulceration or swelling over the leg. There is no history of any prolonged immobilization or a hospital admission in the past. There's no history of any abdominal pain or distension. There's no history of any constipation. The patient had undergone 2 LSCs in the past. In the past history, there's no history of any similar complaints in the past, no history of any comorbidities like hypertension, diabetes, TB, or the chronic cough. There is history of open appendectomy 35 years ago. There's no significant family history which is contributing to the history, sir. Personal history, the patient takes mixed diet, no addiction, bowel and bladder habits are regular, and the sleep and appetite are normal, sir. So the summary of history is a 48-year-old female teacher presented with complaints of multiple dilated veins over the inner aspect of the left lower limb, extending up to the lower leg for the last 5 years. It is associated with pain, which was more towards the end of the day. There are no complaints associated with the opposite lower limb or the abdomen.
Sir, Kanagaveli, sir?
Should I continue, sir?
No, Soil, Dr. Soil.
Yes, sir. Yes, sir.
She's a 48-year lady.
Yes, sir.
She was having this problem for 5 years.
Yes,
What
sir.
has made her come to the hospital now after 5 years?
So the pain has the pain, sir. The pain is now aggravated, sir.
So since how long has the pain increased?
So the pain since the last 10 days, sir. She's a teacher of occupation, sir. So since last 1 year it is there, sir. But now it has aggravated, sir.
Okay. No other complaints.
No other complaints.
Okay, let's go to your next slide, please. So why do you think she's having pain now? And the pain is right. Yes, ma'am, please. Ma'am, please.
What are the various other occupations which can be linked with varicose veins?
Various other occupations, the occupations which demand prolonged standing, sir, like bus conductors or the patient or the people in the teaching profession.
Okay.
What about surgeons?
Yes, sir, surgeons are also included, sir.
Just joking.
Not seeing surgeons.
I've not seen any surgeon. Yeah, barbers they have.
Usually
Barbers are very
surgeons,
common.
they
Barbers.
do. Barbers, they do have. Traffic policemen,
Yes,
they do
sir.
have.
Barbers,
Even the
traffic
hotel,
policemen.
the waiters, these people, they do have.
Yes.
Teachers, these are the occupations, they do have varicose veins.
Varicose veins, prolonged
Okay.
standing.
What is the age group in which you tend to have this varicosity? Your patient is around 48.
Yes.
No, what is the age group around which you have?
Varicose vein usually presents in middle age group patients, ma'am. Mostly as the age increases, the risk of varicose vein increases, ma'am.
So elderly persons, the more amount of varicosities they tend to develop.
Yes, sir.
Okay, as you said, as the age advances, it increases. Why does it happen in elderly age?
Due to the paucity of the walls, due to the valvular damage into the venous system of the lower limbs.
Long-standing hydrostatic pressure
Long-standing hydrostatic pressure
might be one of the
increases.
reasons.
Yes, ma'am. Yes, ma'am.
Okay. Okay. What are the other causes of pain in the lower limb?
The other causes of pain in the lower limb.
You said that's the dull aching of pain, no?
Yes, ma'am. If the patient is having peripheral vascular diseases, the patient will have pain, and the patient with diabetic neuropathy,
Okay.
lower limb pain.
Okay. So there could be an arterial claudication, venous claudication, or a neurogenic claudication, which are the
Yes.
most commonest one. Apart
Yes,
from that, what are the other reasons of pain in the lower limb? Which we see nowadays very commonly. We see a lot of people, they do have this vitamin D deficiency,
Okay.
which has
Vitamin
been
D.
implicated in this lower limb pain. Okay. So
Yes.
how do you differentiate between an arterial pain and the neurogenic pain, and even an osteoarthritis? In an elderly person, there could be a pain due to an osteoarthritis. How do you differentiate between a neurogenic pain and an arterial pain?
So, neurogenic pain is usually associated with sensory deficits, ma'am. And then the pain due to arterial claudication usually worsens when the patient doesn't exercises due to the inadequate arterial blood supply, ma'am.
Okay. So which produces pain on the first step?
Pain on the first step, ma'am.
So when you have a nerve compression,
Yes, ma'am.
okay,
Sciatica
when
or
the
the
patient starts moving,
Yes,
sciatica, at that time there will be a pain on the first step. So neurogenic claudication usually starts from the first step of the pain.
yes, ma'am.
Okay, right. Okay, we'll go on to the next slide. What are the why does a person get a night cramp?
Uh, in varicose vein patients sometimes experiences night cramps, ma'am,
Why does it happen?
due to the stasis of blood, ma'am.
Okay, but why at night? So usually during the morning time, at that time the patient tends to work,
Yes.
and as the day progresses, there is going to be a stasis. When the patient
Yes.
hits the bed, what happens? It tends to empty, and the blood gets diverted. At the time, the
Yes.
muscle starts contracting, and the patient feels the cramp. So that is the reason why the patient, they tend to have this night
Night cramp.
cramps. Okay. Why did you ask history of trauma?
Any history of trauma leading to any hematoma formation, ma'am, or like muscle pains, ma'am? To
Hematoma.
differentiate it from, yes,
How does
ma'am.
hematoma come in relation with the varicosity? Think something else. Any trauma can lead on to a development of a arterial venous fistula. That might be a reason for this varicosity.
Yes, secondary varicose.
AV fistula.
AV
Okay.
fistula.
Which might be associated with varicosity, secondary varicosities. So that is the reason you need to ask about trauma.
Yes.
Okay.
Also DVT. Trauma can lead to DVT.
Yes, sir. Trauma can lead on to DVT. Yeah. Okay. Why did you want to know about history of itching over the leg and the ankle?
History of the itching and over the leg and ankle like points us towards the venous stasis and skin changes, early skin changes, ma'am.
Usually patients will have a small trauma or something, they tend to scratch and this itching will aggravate.
Yes,
Okay, whenever there's going to be their stasis, hemostasis
yes,
deposition, it might be this itching. Okay, next slide. Okay, coming on to pigmentation. Okay, will this pigmentation disappear?
this pigmentation due to varicose vein. No, ma'am.
So generally speaking, when you have an advanced case where there's excessive pigmentation, they don't tend to disappear. Okay,
Yes.
but when you have a minimal pigmentation, the early cases, and your patient is very much compliant enough and he's going to wear this regular stockings and other things, then
Yes.
as the years goes on, the pigmentation, they tend to decrease definitely. Okay, right. So what is the difference between a pigmentation due to a varicosity and a pigmentation due to an arterial system of involvement? Sohail, are you audible?
Yes, ma'am. Yes, ma'am. You're audible, ma'am. The pigmentation due to the pigmentation due to the varicose vein usually affects the gaiters area, ma'am. But the
Very
pigmentation due
good.
to the arterial diseases starts in the most distal most part of the leg, ma'am, and progresses proximally,
Very
ma'am.
good. Okay, if
And
the pathology is in the superficial venous system and if the pathology is in the deep venous system, how the pigmentation will differ? When you have a deep venous system is going to be involved, usually the
yes,
pigmentation will be involving up to the lower third of the leg, almost above it is going up. Whereas in
yes,
the case of a superficial venous system, it will be almost confined only to the gaiter area.
yes.
Okay, right. What do you mean by prolonged immobilization? Why you want to know about that?
Any history of prolonged immobilization points us towards deep venous thrombosis, ma'am, or the hospital admission.
How did you
Also point.
elicit this history of prolonged immobilization? What history did you ask?
If the patient is having any disabilities or paralysis, or the patient was admitted for any major surgeries in the past.
Any orthopedic surgeries or the
Orthopedic
patient has
surgery,
undergone any, suffered from any stroke or anything else.
stroke
These
or
will cause a
paralysis.
prolonged immobilization.
Yes.
Okay, right. Tell me, what is the regarding ulceration in the legs you have asked, right? So what are the types of ulcers which can present in the leg?
Types of ulcers, ma'am. Hello, ma'am. The types of ulcers is the question.
Yeah.
Yeah, the types of ulcers are venous ulcer,
Types
ma'am,
of ulcers.
or venous ulcer, or traumatic ulcer, or neuropathic ulcers, ma'am, and arterial ulcer, gangrenous.
Okay, what is the cause for this venous ulcer?
So venous ulcer, the cause is ambulatory venous hypertension is the most common accepted theory. Ambulatory venous hypertension.
Okay, what is the normal pressure in the lower limb at the foot?
The normal pressure in the lower limb foot is around 100 mm of Hg, ma'am. 100 mm of mercury, ma'am.
Where at the venous end or at the arterial end?
Yes, ma'am. We see the arterial end. During the venous end, the pressure is around 10 to 15 mm of Hg, ma'am.
Okay, around the capillaries?
30 to 40 mm. So as we progress toward venous end, the pressure keeps on decreasing.
So, Dr. Sohail,
yes,
what
sir.
is the difference between a venous ulcer and a varicose ulcer?
So, a varicose ulcer occurs when a superficial venous system is involved, sir, and a venous ulcer occurs when a deep venous system or perforators are involved, sir.
Okay, anything else?
Venous ulcer is associated with more pain, sir, but varicose ulcer is usually painless ulcer, sir.
No, not really. Both of them are painless. Painful ulcers are arterial ulcers.
Yes,
Venous ulcers because of the deep veins, so
deep
the
veins,
ulcer
yes.
will be deeper than the superficial fascia.
Yes, sir.
This is above the superficial fascia.
Above the superficial, yes, sir.
Right?
The base
That's the
will be
most
deep
important.
Yes, sir.
And varicose ulcers, they heal if you treat the thing. They heal easily. Venous ulcers don't heal. You must have seen they're having prolonged time. Right?
There's ankle edema in the venous ulcer.
Right. So these are the major issues.
Yes.
Right. And there is a lot of swelling if there's a venous ulcer in the lower limb.
Yes,
varicose ulcers, there's not be much swelling of the lower limb.
There's no swelling in the ankles.
So these are the stuff. Okay.
Well, why does they occur more on the medial side?
So the more on the medial side, the ulcers happen because of the perforators are more over the medial side. Pocket perforators are the more on the medial side, sir. The incompetence of these perforators leads to stasis and the skin changes and increase in the ambulatory venous pressure, sir.
No. The perforators are not. That's not the reason. That's not the reason that there are more perforators on the medial side. So the reason is that you have the great saphenous on the medial side,
Yes.
which has a larger volume of blood, isn't it?
Yes.
That is why, not because of the perforators. There's a larger
Skin,
volume of blood here.
there is hardly any fat in between the skin and the
Skin and
periosity
the bone, yes.
on the medial side. So these are the reasons, because of long saphenous system, and because of this reason, it is more common on the medial side. Jay.
What is this area called?
Gaiters areas.
What do you mean by gaiter? What's the gaiter?
Usually, the gaiter is a piece of clothing which is being worn, sir, near the lower part of the leg, sir, lower one third of the leg, sir, as a protective clothing.
Right. There are horsemen who wear this.
Yes, sir, horseman wear this.
Okay.
And a patient of the varicose veins, if you get the intermittent claudication, what does that mean?
There's an involvement of an arterial system also.
Yes, you must always check for the arterial system in that.
Yes.
If the intermittent claudication is there.
Yes.
What is the prevalence of the varicose veins in the general population?
20% is the prevalence of varicose veins in general population.
So at the age of 60 years, what is the prevalence? It's almost about 2/3 of the population.
2/3 of the population.
About 60 to 70% of the population at the age of 60 years will have the varicose veins. It
Yes.
may be C1 or it may be C2 or any class which is there. And what is the chance of having the C5, 6 disease in population at the age of 60 years again?
40%.
No. It's around 1 to 2%.
1 to 2%.
1 to 2% may have the C5, 6 disease in that. Right. How many perforators are there in the leg?
So there are many perforators, but named perforators are the one which are at the constant locations.
And the perforators which are there in the calf on the medial side, are they along the great saphenous vein?
Calf on the medial side, sir. Yes, sir.
No, they are not on the great saphenous vein.
What?
The main perforators which are there, what you say 5, 10, 15 centimeters perforator
Yes,
on the ankle, they are not on the main perforator vein, main GSV. They are on the posterior arch vein.
Posterior arch.
Posterior arch vein is there. So all these perforators which are there, they are situated over the posterior arch vein and not on the main GSV.
Yes.
What is the name of what's the other name for posterior arch vein?
Vein of Leonardo.
And what are the types of perforators? What are the types of perforators?
There are two types of perforators, sir. Direct and indirect perforators.
So what is the difference between the two?
Direct perforators, the indirect perforators have capillaries, sir, actually.
No, not capillaries. What do they have? They've got sinuses.
The sinuses, sir. Yes, sir. Soleal sinuses. What is it?
Right.
Yes.
So most of these perforators they open into which vein? On the medial side, they open into which vein? Like Sir said, one they open into arc vein of Leonardo.
Yes, sir.
Right. And where does that open?
That opens into the posterior tibial vein.
Okay. And what are the? Do you know the direct perforators?
Direct perforators, sir.
Yeah. Name a few direct perforators.
Main customers perforator at the ankle, sir. And above ankle, there are pocket perforators, sir. And below knee, Boyd's perforator, sir. So
Boyd's is the one which opens directly. Boyd's and then Hunter's.
Yes, sir. Hunter's is Sutter.
And there's some which open on the lateral side, like Sherman.
Why did you ask about history of abdominal pain or the distension?
Any abdominal lump which might be causing a pressure on the IVC or the iliac veins, causes secondary varicose veins in the patient. Sir.
Okay. What is the cause of the pigmentation? The CVI which occurs in these patients, what is the cause of pigmentation? What are the things they cause the pigmentation?
The cause of pigmentation is due to deposition of hemosiderin, sir, as well as melanin production, sir.
Good. Yeah, hemosiderin and the melanin, both
Yes,
are responsible for that.
Yes, sir.
What is the ambulatory venous pressure?
So ambulatory venous pressure is the failure of it is the failure of the reduction in the pressure in the superficial venous system upon exercise is known as ambulatory venous pressure. Sir.
Like when you are standing, you said it is at 100 millimeter mercury, isn't it?
Yes, sir.
And when you walk, how much the pressure is?
It drops down to less than 10 mm of Hg, sir. Less than 10 to 20 mm of Hg, sir.
Yes. So is that ambulatory venous pressure is more important for causation of the venous ulcer, or it is the standing pressure which is more responsible for that?
Ambulatory pressure, venous pressure is more important, which causes
ambulatory venous pressure is directly associated with the
venous
incidence of the venous ulcer.
Yes.
So the normal pressure may be same in a person who has the varicose, who doesn't have the varicose veins.
Yes.
The ambulatory venous pressure will be definitely higher in the patients where there is a varicose vein and the varicose ulcers are there.
Yes.
Okay. And go to the examination now.
This is the clinical image of the patient, sir. The general examination of the patient. The patient was cooperative and well oriented to time, place, and person. The patient is moderately built and moderately nourished. Her Karnofsky performance status is 90. Her BMI is 24.8. Sir. The vitals of the patient are the patient is afebrile, pulse is 82 per minute over the right radial artery and regular in rhythm, normal in volume, no radiofemoral delay. Her BP is 130 by 80 mm of mercury over the right upper arm. Her respiratory rate is 18 cycles per minute and abdominothoracic. There is no pallor, there is no lymphadenopathy, there is no pedal edema. So local examination of the left lower limb. The patient was examined in a well-lit room after taking an informed consent and exposing her from the groin to the below. The patient was examined in different positions when and where required in presence of a female attender. On inspection of the left lower limb, multiple varicosities noted over the medial aspect of the foot, medial aspect of the thigh and the leg along the course of the great saphenous vein. No pigmentation is seen, no visible scars or ulcers, no evidence of loss of hair, brittle nails, dry skin, or loss of subcutaneous fat. Right lower limb appears to be normal. On palpation, there is no local rise of temperature. There is no tenderness in the calf. There is no evidence of thickening along the vein. On the different test of varicose veins, Brody Trendelenburg test 1, which is positive in the left lower limb, indicating left SFJ incompetence. Brody Trendelenburg test 2, it is positive in the left lower limb, indicating incompetent perforators in the left lower limb. Multiple tourniquet test shows incompetent perforators noted below knee, above ankle at 5 cm and 15 cm above the ankle. Figen's test shows the palpable defects below knee and above ankle. Modified Perthes test, on modified Perthes test, there is no evidence of any deep venous occlusion. On Schwartz test, a thrill is palpable over the SFJs. On tapping the GSV, Morris's cough impulse is positive over the left SFJ. The Homan sign and Moses signs are negative. All arterial pulsations in the left lower limb are palpable, and no evidence of any sensory or motor deficits. Bilateral inguinal lymph nodes are not palpable, sir. On percussion, there is a thrill present over the left SFJ on tapping over the course of GSV. On auscultation, no bruit or murmur heard. Abdominal examination, no dilated veins over the abdomen. It is soft and non-tender, and no palpable lump in the abdomen. On systemic examination, cardiovascular system, S1, S2 is heard and are normal. No murmur is present. Respiratory system examination shows trachea in midline, bilateral air entry. No added sounds are present. On the nervous system examination, the patient is conscious, cooperative, power in all the four limbs is 5/5, and reflexes are normal, sir. So the summary of the case is a 48-year-old teacher with a 48-year-old teacher with complaints of dilated veins over the inner aspect of the left lower limb extending up to the leg for the last 5 years, which is associated with pain for the past 1 year, which was more for towards the end of the day. On examination of the left lower limb, there are varicosities involving the left greater saphenous vein with findings suggestive of incompetent left SFJ and incompetent below knee perforators along with above knee perforators with no evidence of any DVT or venous insufficiency. So the diagnosis is the primary varicose veins of the left lower limb involving the great saphenous venous system with SFJ and perforator incompetence with no evidence of venous insufficiency or DVT. The CEP score is C2, EP, A, S plus P and PR.
Well, why did you tell us about the Karnofsky score here?
If the patient is the varicose veins, or the patient is having problem, is it hampering her daily activities? How is she able to perform the daily activities?
Is the Karnofsky score is for that, or it is for some specific purpose? Karnofsky is mainly only for the malignant cases, isn't it? Okay, so if you are suspecting somewhere the malignancy, then it is okay. But otherwise, normally Karnofsky and the ECOG ECOG score,
yes, sir,
not there for the non-malignant cases.
Okay.
Right?
Yes.
Dr. Sohail, your diagnosis is primary varicose veins.
Yes, sir.
And did you
What's the
mention
difference between primary
API
varicose veins and secondary varicose veins?
Primary varicose veins, sir, there is no underlying causative agent which is causing the varicose veins, sir. In the second, sir,
is that it? Basically, there's no it's positive family history and no family lack of family history.
Yes, sir.
Here, primary and secondary is not because of underlying cause.
Yes,
it
sir.
may be that the deep veins may be abnormal, but primary is generally seen in adolescence with family history.
Yes, sir. Positive family history with adolescent age group.
Right.
Yes, sir.
And only the saphenous is involved.
Yes, sir.
Right. Perforators will
Many
usually not be
syndromes.
involved.
Perforators
Perforators
are
will not be
involved, sir.
involved usually in primary.
Yes, sir.
Any syndrome which is associated with varicosities?
Triple syndrome is the one which is associated, ma'am, with the varicose veins, ma'am.
What are the components of KT?
Yeah. What is the components of KTS?
It has a hemangioma as well and varicose veins, sir, and there is a hypertrophy of the soft tissue and lengthening of the limbs.
Okay. So there are there are lots of difference between primary and secondary. This is the why have you labeled her primary? That I couldn't understand. Look, we don't know, so you just say it as varicose veins. You don't have to label it.
Yes.
But it doesn't fit into primary at all.
Yes.
She's an elderly lady. She's not elderly. She's a middle-aged lady.
Middle-aged.
Right? With no family history. Right? So all that this thing is her perforators are involved, aren't they?
Yes, sir.
So that rules that out.
So the primary basically the idiopathic variety, isn't it?
Yes,
you
sir.
really do not know the cause that what is happening. But secondary one is which is secondary to some cause. Yes. Like a patient had a DVT, or a patient has got the arteriovenous fistula is there, or there's the abdominal lump is there, pelvic malignancy is there, pregnancy is there. So they are the secondary one. Okay, so primary is idiopathic where you are not really knowing the cause about that, isn't it?
Yes, yes, sir.
So what are the factors here which is present to say that there's a incompetence present in the perforators?
To 2 years.
Which are the tests? Which are the tests we have done to say there's a perforator incompetence?
Trendelenburg test, ma'am. Two.
International president ஆகிட்டாங்க.
And Fegan's test, ma'am, and multiple tourniquet test, ma'am.
Well, of all these tests which are there, in which test you have to empty the vein first, and which you are not to empty the vein?
Yes, sir. In Brody Trendelenburg tester, we have to empty the vein, sir.
Yes.
And in Fegan's test, we have to empty the tester. And in multiple tourniquet test also, we have to empty the vein, sir.
Yeah. In which you are not to empty the veins?
Pratt's test is the one which we
அதே மாதிரி போட்டு international president.
in
How is the
Pratt's-
modified Perthes test done?
Is not done. No?
Okay, in
Where you are
Perthes test,
you are
modified
putting
Perthes test,
HMR bandage, that is
Yes, sir,
usually
yes.
not done.
yes, sir, not done, sir. Modified Perthes, we need not to empty the veins, sir.
Yes, and then if you have to look for the cuff impulse, then you need not to empty the veins.
Yes, sir.
3 round
Schwartz test also.
Now, when you did the multiple tourniquet test in this patient,
Yes, sir.
which tourniquet did you open first?
அது விட்ரா பண்ணிட்டு.
Like if you put 4 or 5 tourniquet there,
Yes, sir.
which one did you open first?
நிறைய இருந்தாங்க பட் எனக்கு நிறைய ஆப்பிரிக்கன் மக்களே நிறைய
The one which is more proximal, sir, more towards proximal side, sir.
Proximal or distal? It's always the most distal first.
Distal part, near the most distal one.
Not the proximal. Proximal will tell you about the saphenofemoral junction.
SF junction back.
So the most distal first. Right?
Below upwards.
Yes, sir.
Below upwards, yeah.
That is the way it goes.
Did you do the ABPI or you thought about doing ABPI in your patient?
I thought about doing the ABPS, sir.
But you are not told anywhere.
Yes.
You should have told.
Yes, sir.
Right? That is a part of the venous examination.
Venous examination.
So even if you do not have a Doppler with you, but you can at least tell so that the examiner knows that you have this in mind. Okay, so in all cases of venous disease, ABPI has to be told.
Yes, sir.
What is the significance of the ABPI in a venous disease?
In the application, if the patient is having ulcers, sir, for the application of compressive bandages, sir, like we have to be cautious in the patient with less ABPI, sir. The pressure to be applied, grading of compression bandages. Sir.
2.5 billion.
And then if it is an associated ulcer is there, arteriovenous ulcer is there. So both the reasons are there for that you should measure the ABPI in this patient.
Yes, yes.
He directly reports to Charles.
Now you said there is no insufficiency. What does that mean? When you say it is insufficiency?
In venous insufficiency, sir.
No, you have written something. Go to the diagnosis.
Yes, sir. On the last line, sir. No evidence of venous insufficiency or DVD.
What does that mean?
Venous insufficiency in the sense like, sir, the patient having skin changes, like itching or pigmentation.
So when you will say venous insufficiency, up to from what stage you will say it is a venous insufficiency?
Patient when they start to develop skin changes or the symptoms of skin changes.
So that's what I'm asking. In the SEEP classification,
yes, sir.
When you will say the patient is insufficiency?
C3, sir, actually.
C3 onwards.
Yes, yes.
So up to C2 is the varicose veins.
Varicose veins. C3 is pigmentation.
C3 onward is the CVI, chronic venous insufficiency.
Yes, sir.
Because your patient does not have the C3 here.
Yes,
it is only up to C2. That is why you can say that there is no insufficiency.
Yes, sir.
Now, what is the modification of the SEEP which has come? Any idea? In the recent years, the SEEP has been modified.
Yes, sir.
So what is that modification?
don't remember, sir.
In the modified CIF which has come in 2020,
So,
so one of the things which has been added the recurrence of the disease. So if there's a C2 recurrence is there, means only the varicose veins are recurrent. So C2R is there.
C2R.
Similarly, there can be the C5 or C6R may be there. The venous ulcer is recurring back.
Yes.
Right? And second thing is the corona. You know what is the corona phlebitica?
Oh.
What is that? Okay, this is basically there is a flare around the ankle. Is there.
Ankle. Yes, sir.
So it was
Malleolar
initially
flare.
thought that this is a C1 disease.
Telangiectasia.
But then ultimately it was found that those patients who have got the corona are very likely to develop the active ulcer. So from C1 it came to the C4C.
Sure.
Okay, so it has become a C4C now in the recent classification.
Okay.
And third in the etiology which is there, that it has been added there whether it is the extravascular component or it is the intravascular component.
Okay.
So if something is pressing from outside like a May-Thurner syndrome is there, then it has been classified separately as compared to a patient who has a DVT where it is a intravascular is there. And third is the anatomical A which is there,
Yes.
where now there is the name of the vessel. Initially there were the segments were there, but now the proper name is given for that particular vessel to describe it. These are the modifications which has come in the modified CIP classification.
Dr. Sharad, can you please mute yourself? Dr. Sharad. Yeah. Why does the lipodermatosclerosis occur?
Lipodermatosclerosis occur due to the stresses, ma'am. The thickening of the skin and pigmentation and eczema of the skin, ma'am.
Just thickening alone. Anything more? Just
Induration of the
pigmentation first. That is okay. After that,
Yes,
what
ma'am.
will happen?
Eczema, dryness as well as itching.
There's going to be sclerosis there.
Sclerosis, that's true. Fibrosis,
Okay.
sclerosis of the skin and subcutaneous tissue.
Tissue. And there's going to be a fat deposition around that area. This will give you the appearance
Yes,
of a bark-like appearance. Okay.
yes, ma'am.
Where do you get this inverted champagne bottle appearance?
Inverted champagne bottle appearance is seen in the cases of advanced cases of varicose vein, ma'am, where the skin gets fibrosed and thickened. So the ankle part is narrow as well as and the calf part is bulky. So that gives an inverted champagne bottle appearance.
And the varicose vein, they can affect the bone and the joints.
Varicose veins can affect bone. Yes, sir.
What is that called as? That is called a phleboarthrosis.
Phleboarthrosis.
Okay. So they can affect in the later phases, they can affect the bones and the joints here. Okay. So what are you going to do for your patient? Yeah, please, madam, ask. Yeah, please.
What is atrophia blanchi?
What is atrophia blanchi? The superficial veins over the leg are replaced by the white patches, ma'am. And this is the most common site where the ulcer develops, ma'am.
Okay. Okay. How do you want to proceed in this patient?
In this patient, sir, I would like to do basic blood investigations, and I would like to advise an duplex scan of the lower limb, ma'am.
So what do you want to see in the duplex scan?
So duplex scan, we advise to look for the presence or absence of reflex in both superficial and deep venous system, and the distribution as well as the extent of the reflex, and presence or absence of deep venous system occlusion, and any perforator incompetence which is there.
In which position you examine the patient for the duplex scan?
We do in a standing position.
Standing position with?
Standing position with slightly external rotation of the legs.
And patient putting the pressure on the opposite limb.
Yes, sir. Weight over the opposite limbs.
Right. So when you say there is a saphenofemoral incompetence is there,
when will you say saphenofemoral incompetence? When on the duplex scan, there's a reflex which is lasting for more than 0.5 seconds, sir. On Valsalva or on the pressing the calf, sir. So in that situation, we say it is a reflex is there, sir, SF incompetence.
okay. And when do you say the perforator incompetence is there?
Perforator incompetence, sir, 0.3 seconds. Sir.
Along with? Always it is along with something. Along with defect in the deep fascia.
Yes, a defect in the
It should be more than 3.5 millimeters. Okay, so both the things are there. There's a reflux more than 3.35 seconds and diameter of the deep fascia defect is more than 3.5 millimeters.
Yes.
Then only say it's a incompetent perforator. Now, if you have to see one thing on a duplex scan, I say just tell one thing, what you want to see.
The patency of deep venous system.
Yes. So you have to exclude the patient doesn't have the deep vein thrombosis, because your policy of the treatment will absolutely change based if there is a deep vein thrombosis is there. Okay. What other investigations can be done for the diagnostic purpose?
Doppler scan can be done, sir, in the areas which is duplex scan is not available.
No, that you said the Doppler scan we have done. Yeah.
Yes,
What other investigations which may have to be done in the patient with varicose veins? Plethysmography?
Sir?
Plethysmography?
Yes, sir. Plethysmography. Marking of the venous system.
Yes. Then you can do the ambulatory venous pressure measurements.
Yes.
Then you can do the NGOs, no? CT venography or MR venography.
And MRI venogram.
Yes. What is IVUS?
IVUS is, sir, is both superficial and deep venous system. We obliterate, sir, by using endovenous ablation, sir.
No, what is that basically? It's a just like ultrasound, you know?
Yes, sir.
IVUS is an ultrasound, intravascular ultrasound. That is IVUS, you know? And in which case of the varicose veins you would like to do a IVUS?
Patients with the accessory saphenous vein is present.
No, that can be seen on the Doppler, isn't
Doppler.
it? Simple Doppler, it can be seen. That accessory vein can be very simply seen on the Doppler. So once there is a recurrent varicose veins are there,
Okay.
and there is you are suspecting the patient is a deep venous reflux is there.
Yes. Anatomy is
In
variable.
those cases, you have to check for the either with the angiography or the venographies and the IVUS. You know?
Yes.
Okay. So what is your plan of treatment in this patient after you have done that?
The plan of treatment would be like the gold standard of treatment these days is EVL, endovenous laser therapy, sir.
Gold standard is?
Endovascular laser therapy, sir, with an outpatient
In
treatment.
all cases of varicose veins, you are going to do that is the gold standard.
No, sir. Open trundle bulb surgery also.
No. So all cases of varicose veins, they require the surgery.
No, sir.
I told you the prevalence of the varicose vein is almost 2/3 of the population.
the
So are you going to do the surgery for all the?
No, sir.
So when are you planning to do the surgery for the varicose veins?
The patient has a discomfort due to the pain, sir, or discomfort due to the pain, sir. Pain.
Patient must be symptomatic.
Symptomatic or complications of the varicose veins are present.
Symptomatics and the complications. So
And
these are the indications for carrying out any active treatment.
Yes.
Or just seeing few varicose veins which are there, few dilated veins on the limb, doesn't make a patient candidate for the surgery.
Yes, sir.
Okay. Yes, please, madam, ask.
So when I want to plan for a SSJ ligation, what are the tributaries you are going to ligate?
At the subject, there are 6 tributaries, ma'am. We have to ligate it to prevent the recurrence, ma'am. There are 2 lateral tributaries, 2 medial tributaries, and 2 distal tributaries, ma'am. 2 lateral tributaries are superficial external, superficial inferior epigastric vein, ma'am, and superficial circumflex iliac vessel. Medially, there is a superficial external udendal vessel and deep external udendal vessel. And distally, there is anterior accessory saphenous vein and posterior medial thigh vein.
Okay. Do you strip always the saphenous vein, or you don't?
So stripping is associated with the least recurrence. So stripping is preferred now of the GS.
How far will you strip if you want to strip?
Stripping beyond the upper 1/3 of leg is not recommended, ma'am, due to the high incidence of damage to the saphenous nerve.
What will happen if the saphenous nerve gets damaged?
Patient will have
an altered sensation over the middle aspect of it.
Neuralgia,
Paresthesia.
saphenous neuralgia is the
Would be there.
What
Okay.
are the other nerves which can be damaged during the varicose vein surgery?
short saphenous vein surgery. This sural nerve can be damaged, sir, or common peroneal nerve can also be damaged, sir.
So, saphenous nerve, sural nerve, and the lateral popliteal, the common perineal nerve.
Common peroneal.
Right. Okay. So up to
What is the name
level
of
you
the
will strip?
stripper?
We use Mayer stripper.
And up to what level you are going to strip?
Up to the upper 1/3 of the leg, sir.
How will you introduce the stripper?
It's around the knee, no?
Yes, sir.
Usually you should not go below the knee.
Below the knee, sir.
Okay, so you should strip only in the thigh.
Yes, sir. Stripping is done from above downwards, ma'am.
Stripping is done above downwards.
Yes, sir, from up to
How
down.
do you introduce the stripper?
How will you introduce stripper? We do phlebotomy, ma'am, and introduce the stripper at the lower end, ma'am. And at the SF junction, we like it or the remaining tributaries, ma'am. And then after passing the guide wire, we attach the acron heads, ma'am. And then we strip the vein.
Okay. How do you approach the perforator veins?
Perforator veins, ma'am, we can do multiple perforator ligations, ma'am, as an open procedure through phlebotomy.
Stab avulsion and ligation.
Stab avulsion and ligation, phlebotomy.
Can you do any endoscopic surgery for the perforators?
Yes, sir. Subfacial endoscopic perforator ligation.
Is it a very popular technique or it is now the obsolete technique now?
It's a popular technique, sir. It is useful when the patient is having lipodermatosclerosis changes in the lower part of the limb, sir. But the skin is diseased. Sepsis preferred.
This was a technique which became popular I think about a decade back. But because of the associated complications of that, and because you are only going to tackle only the perforators which are on the medial side.
Yes, sir.
Okay. This technique has not picked up very well yet. Okay. But this is good for the patient who has got lipodermatosclerosis because you are avoiding the disease area.
Yes.
But because of all these things, it is not becoming very popular now. So
Any other method for?
Ma'am?
Sir, continue, sir.
What are the various other techniques, recent techniques which are there for the varicose veins?
Endovenous laser ablation, endothermal techniques are there, sir. Endovenous laser ablation or radiofrequency ablation techniques. Sir.
And? Yeah, it's endovenous laser ablation and?
Radiofrequency ablation.
Okay.
And sclerotherapy.
In the endovenous ablation therapy, you can divide whether they're thermal or they're the non-thermal.
Non-thermal.
So what are the thermal and what are the non-thermals?
Thermal, we use lasers, sir. In non-thermal, we use electromagnetic mechanism, sir.
What laser is used?
Sir?
What is the electromechanical you said?
Electromagnetic waves are used, sir.
Electromagnetic waves. I'm not sure what is that. Okay, the third one is the laser and the radio frequency ablation.
Yes.
And nowadays the steam is used and the microwave is used. So these are 4 types of the thermal ablations. But the non-thermal is what is called a MOCA. Have you heard the name MOCA? MOCA? MOCA is mechanico-chemical ablation.
Yes, mechanico-chemical ablation.
Mechanico-chemical ablation, where you are doing mechanical plus sclerotherapy.
Yes.
Then you can do only the sclerotherapy.
Yes, sir.
And third is that you can use a glue.
Yes, sir.
Okay. Nowadays, the most recent is the non-invasive method. You know what is the non-invasive method of treatment of varicose veins? That is called a HIFU. HIFU. High frequency ultrasound. Okay, so these are the latest in the treatment for the varicose veins. But the most popular one is the endovenous laser treatment.
Laser ablation.
EVLT. So which laser is used? Which laser is used for the varicose veins?
The frequency, sir?
No, you know, there are so many types of lasers are there.
Yes,
you can have the NDAG, you can have the diode, you can have the helium.
Diode laser is used. Diode laser is used.
Diode is the one, which is used.
Yes.
But you know where the NDAG is used for the varicose veins? NDAG can also be used.
NDAG or the diode laser, both can be used.
Yes.
So NDAG is for the spider veins,
Spider veins.
When you are doing the that is called a cosmetic phlebology. Okay, when you are using the veins for like there are small bluish veins are there. There you use the NDAG,
Yes.
You know what is CLAX?
What is the wavelength which is being used for RFA?
For laser we use around 1470, 1470 nanometer laser, the wavelength.
Yes.
Of the laser.
Previously, what was used? The current one is 1470. Previously,
yes.
There was yet another one, no? 980 something.
980, 8810 to no 980.
In WhatsApp.
Why we switched over from that one to this?
More localized with less tissue damage in the 1470, as well as
That causes more of thermal ablation.
Yes, less burns to be needed
Yeah.
for this time.
Hello?
So
And
that's why
now
we
there is
switch over to
1940, isn't?
Yes, sir.
The most recent one is the 1940. Ahead of the 1470, it is 1940 now.
Yes, sir.
Okay, so when you are doing the laser ablation, what precaution has to be taken?
The precautions related to the laser dissemination, sir. The safety goggles as
All
well as.
precautions for the laser, any laser. So
Yes,
you
sir.
must protect your eyes, the patient's eyes, and all those things.
Yes, sir.
But what is there when you are doing the laser?
What is?
When you're doing the laser treatment,
Yes, sir.
your fiber is in the vein.
Yes,
What
sir.
precaution you have to take?
Fiber is in the vein. We
What should be
have
the,
to.
where should be the tip of the fiber?
Tip of the fiber will be beyond the cannula, sir. Actually, 2 centimeters beyond the cannula, and the
Where?
vessel should be
What
empty.
is the location? It must be at least 2 centimeter
Beyond the
proximal to the saphenofemoral junction.
Yes, sir.
Okay. You should never be going around that.
Yes, sir.
Otherwise, what can happen?
Damage to the deep venous system, or else.
What is that called as? It can cause a thrombosis there.
Yes, sir. Yes,
And that
sir.
is called a E-hit.
E-hit.
Endo heat induced thrombosis. Okay, it can cause
So what type of laser fiber will prevent this? What are the types of fibers? The bare fiber and the radial fiber.
Radial fiber.
Radial fiber is going to be inside the thing. So what happens? The surrounding illumination is going to be avoided with that. That's the advantage.
And what is tumescent anesthesia?
Tumescent anesthesia is injection of the lignocaine solution around the vessel to cause the hydrodissection, to avoid the injury to the subcutaneous as well as the skin cell, so that the treatment remains confined to the vessel.
So can you do the laser for the perforators also?
Yes, sir.
Can be done also for the perforators.
Yes, sir. Yes, sir. That is the advantage.
Now tell something about the sclerotherapy.
Sclerotherapy, sir.
Which drug is used for the sclerotherapy?
Sodium tetradecyl sulfate is used, sir, most commonly for sclerotherapy, sir.
What type of the therapy is used? Is it a liquid or it is something else?
Foam, sir. It's a foam sclerotherapy.
It's foam. And how do you make the foam?
What does the foam contain?
We make.
What is the agent?
Sodium tetradecyl sulfate is taken with the ratio of 1:3 or 1:4 with the 3-way cannula. We used SRE method, ma'am. We mix by two syringes with 3-way cannula to increase the volume. It helps to displace the blood as well as increases the surface area of the sclerostin, ma'am, and causes less use of sclerostin.
What are the other sclerosins which are available?
Polidocaine or polidocaine is one of the sclerosin, man.
Polidocanol, no, not polidocaine. Polidocanol.
It's not something.
Yes.
Not.
And then you can use the
Not like
dextrose, you
lignocaine.
can use the alcohol, you can use the hot water. All these has been used for the sclerotherapy. Yeah? And what about the MOCA, mechanico-chemical?
In this, we introduce a catheter and we damage the endothelium, so subsequently by injecting the sclerocenter to increase the effectiveness of sclerotherapy.
Yes. And what about the glue?
Endoglue we use cyanoacrylate, sir.
So what
And
precaution you have to take when you are putting the cyanoacrylate? As you
we-
put your tip of the catheter in the laser 2 centimeters
Yes, sir.
away from the saphenofemoral junction, what is done in the when you are injecting the glue? It
We
should be
have
at
to
least
see
5
Yes,
centimeters.
sir. We have to be precautionary. It doesn't.
Because if this glue goes into the deep veins, and there is no way to take it out.
Yes, sir.
So it has to be at least 5 centimeters from the saphenofemoral junction.
Yes.
So what are the complications of the endovenous treatment?
Complications of endovenous system, sir. Sclerotherapy, sclerotherapy, the complications are pigmentation, sir, or thrombosis, phlebitis, sir, superficial or deep venous system thrombosis, sir, or anaphylactic reactions to the sclerosins, allergic reactions. Sir.
And also neuralgia. Neuralgia is
Neuralgia,
also
sir.
the complication.
Yeah, yes.
Right. And then there can skin burns may be there.
In burns with the laser surgery.
Right. Okay. So what are the causes of recurrent varicose veins?
Causes of recurrent varicose veins are the tributaries are failure to ligate the tributaries, sir, at the SF junction is one of the cause for recurrent varicose veins.
Yes.
As well as neovascularization of the stripped area of the GSV, sir, is one of the cause of recurrent varicose veins. And inadequate stripping of the GSV, sir.
Yes. And what is the usual treatment of the recurrent varicose veins?
What are the different types of stockings available for varicosities?
There are 3 grades of stockings available for varicose veins according to British classification. Class 1 is 14 to 17 mm of Hg. Class 2 is 18 to 24 mm of Hg, and class 3 is 25 to 30 mm of mercury of pressure stockings.
So which one you prefer for prophylactic advice?
Prophylactic advice, we advise class 2. Below knee is preferred.
Okay.
So what is the treatment for the recurrent varicose veins? What is the commonest treatment for the recurrent varicose veins?
Sclerotherapy is the preferred
Thank you.
treatment, sir, for the recovery.
Sclerotherapy is the most popular treatment.
Yes, sir.
And still, even after that, it is still there. Then you have to work up the patient for the deep venous insufficiency, which is there. So you have to go for NGOs and the IVs for patients to check for that.
Yes, sir.
Okay, I think. Madam, can we stop here now? Dr. Kanagavan?
Yes, sir. We'll
Thank
go
you.
with the next
Take
one.
one more,
Ajay
please.
Khanna, sir, Anande madam. How do you rate our students, sir?
It's very good.
Thank you.
Yeah, I appreciate. Yeah, I appreciate it. It's very good. Yeah.
Thank you, sir.
Yeah.
I think we can ask the other student to present his case. You can stop sharing, Sohail.
Yes, sir. Yes, sir.
Other student is there?
Yes, sir.
He's back, sir. He's back with us. Sir.
He's back.
Okay.
Kalai, I think you started presenting. You quickly run through again from fresh so that then it becomes easy for the faculty to follow up.
Yeah, okay, sir.
Yeah. Quickly run through the presented slides and slow down once you reach the slide where you stopped in.
Yeah, okay.
Go ahead. You adjust your video, you are not seen properly. Yes.
No.
Good. Please start.
A 62-year-old female from Thoothukudi, housewife, came with complaints of ulcer in the tongue for 6 months, complaints of swelling in the left side of the neck for 3 months. Patient was apparently normal before 6 months. Later, she developed ulcer over left side of the tongue, which was initially small in size, slowly progressed to attain current size. Insidious onset, progressive in nature, associated with pain during chewing, dull aching, not radiating, no history of bleeding from ulcer. Swelling of the left side of the neck for the past 3 months, which was insidious in onset and progressive nature, not associated with pain. History of excessive salivation is there. History of difficulty chewing and speech is there. No history of ear pain, no history of trauma, no history of use of dentures, no history of loss of weight, appetite, no history of breathlessness, no history of difficulty swallowing, no history of halitosis, no signs and symptoms of Farner syndrome. Past history, no known comorbidities, no significant surgical history, no history of any drug allergy, no history of any dental interventions in the past. Personal history, patient takes mixed diet, normal sleep pattern, normal bowel bladder habits, not an alcoholic smoker, tobacco betel nut chewer, attained menopause 15 years back. General examination, patient is conscious oriented, afebrile, hydration fan, no pallor, no ectric, issue was 0, dental formula 2123, 2123. Sorry, sir, I have to stop with the history, sir.
Go ahead. Okay, we started with the history. No, we'll finish it off. We were discussing about, I think you answered everything almost, right? What are the causes of the pain? Why does it go to the ear? And from the posterior third of the tongue, how does it reach the ear? That was the question which was asked. And I think there we went off.
Yes, sir. From the posterior third of the tongue is supplied by the glossopharyngeal nerve.
Yeah.
Via the tympanic plexus,
Both
the
the
pain
place.
radiated to the ear.
Okay. In the presenting illness, you can also ask about a history of any loosening of tooth.
Yes, ma'am.
Okay. And in your personal history regarding this patient is not an alcoholic, neither a tobacco chewer.
Yes, ma'am.
Okay, right. If at all this patient is going to be a tobacco chewer, how does tobacco cause as a relation with an oral cavity malignancy?
Tobacco and areca nut have a carcinogen, tannin, and that tobacco itself causes irritation. Overall, they keep the mixture of tobacco, areca nut, and the lime in the gingival circles overnight. It increases the risk, causes constant irritation, and increases the risk of malignancy.
So there is irritation, inflammation, and further leading on to mutational changes in the P53 gene. That is the one which is going to halt anything which is going to become cancerous in our body. So when there is going to be a change or a mutation in the P53 gene, then further cancer starts to come inside, right? How does alcohol influence malignancy?
Alcohol acts as a promoter and irritant, and it impairs the DNA repair mechanism. And it also
alcohol along with tobacco, it will see alcohol with tobacco, it can act as a promoter or a solvent, right? Per se, if at all a patient is not a smoker and only an alcohol, in that case, how does it
impairs the DNA
to produce a malignancy?
It impairs the DNA repair mechanism.
What is alcohol converted into?
Aldehyde, ma'am.
Aldehyde. So this aldehyde is the one which is going to be the more culprit fellow, which can potentiate malignant changes to develop. Okay. Right. So the oral cavity bacteria, which is going to be unhealthy bacteria, so the oral hygiene is going to be impaired. This bacteria has the capacity to convert this alcohol into aldehyde. Otherwise, whatever alcohol the patient is going to be taking, it gets converted only into aldehyde in the liver part. Okay, but when the local aldehyde formation happens, this leads on to a DNA damage, and this results in the development of malignancy. Okay, right. So, what kind of dental intervention you wanted to ask upon this patient?
Is there any previous history of dental caries or sharp tooths that lead to irritation to the tongue that was removed? I like to ask about it.
Very good. So sharp tooth is whenever a person doesn't have any risk factors like alcoholic or smoking, any history, non-tobacco kind of related one, then think about sharp tooth as the predominant cause for your carcinogenic effect, right? This patient can have a malignancy there. What do you mean by quid? We were talking about quid, no? What is quid?
It is a mixture of tobacco, areca nut, and betel nut. That is and lime kept overnight for highness. For the kick.
So why it is called the quid?
Don't know. Don't
The
know.
culprit is the slaked line. Okay, why it is called quid? See, you have seen on the roadsides a lot of cattle and other things. They will tend to eat whatever is present on the grass or something, and they tend to store it in the quid here. And whenever the time permits, they will
Swallow.
regurgitate back into the oral cavity, and then they will start eating it again. So similarly, these patients, they get the quid in the gingival sulcus here, and they try to push it back inside the oral cavity and chew it and again store it back. Something like you would have eaten this bubble gum like that, right? As a kid. Similar to that, this quid eating habit. Right. We'll go on to general examination. Past history over. Personal history, nothing to be relevant to be asked. Right. Go on to proper examination, proper bingo.
Yes, sir. It's a clinical image of the patient. Local examination. Mouth opening was adequate. Oral cavity, poor oral hygiene. Multiple dental caries was there. No erythroplakia, leukoplakic lesions over the buccal mucosa, floor of the mouth, alveolus, and tongue. Ulcerative lesion 3 × 1 centimeter involving left lateral aspect of anterior 2/3 of the tongue, extending medially 1.5 centimeter from midline in dorsal aspect, on 1 centimeter from midline in ventral aspect, anteriorly 1 centimeter from tip of the tongue, and posteriorly up to the level of second molar when the tongue is inside the mouth. Ovoid in shape, margins are raised, floor is formed by the yellow sloughed tissue, deviation of tongue to the ipsilateral side on protrusion of the tongue was there, no discharge and no bleeding. And a palpation inspective findings were confirmed, no warmth, tenderness was there, base induration was present, no involvement of floor of the mouth and retromolar trigon, doesn't bleed on touch. And examination of the neck, hemispherical swelling of size 4 × 2 centimeter over left side of the neck, level to cervical lymph node, no warmth, no tenderness, firm in consistency, mobile swelling, skin over the swelling is pinchable, no dilated veins or pulsation, no palpable cervical lymph nodes on the opposite right side, no palpable supraclavicular lymph nodes. I go to summary. A 60-year-old female presented with ulcer in the left lateral margin of the tongue for past 6 months and swelling in the left side of the neck for past 3 months with the complaints of excessive salivation and dull aching pain during chewing. On examination, there is an ulcer 3 × 1 centimeter in left lateral margin of anterior 2/3 of the tongue. Margin is raised, indurated base, floor covered by necrotic slough, and a palpable mobile firm level 3 cervical lymph node. This is a case of ulcerative type of carcinoma tongue on left lateral aspect of anterior 2/3 of tongue with nodal metastasis.
We'll go on to the first slide, local examination.
It's an image, no?
Yeah, the first one. You said the mouth opening is adequate. What do you mean by mouth opening? When will the mouth opening be restricted in a person with a tongue carcinoma?
Adequate mouth opening is allowing a 2-finger breadth of mouth opening, allowing a 2-finger breadth.
Okay, it was 3 finger. Okay, 3.5 centimeter.
Mouth opening will be restricted when there is a submucous fibrosis or involvement of the tumor involving the temporomandibular joint, ma'am. Extending
from the tongue, you think there will be from the tongue, you think there will be a temporomandibular joint involvement?
Ma'am, there will be extension to retromolar trigon, and that will lead to
retromolar trigon gets involved in a buccal mucus growth. From the tongue, you think to retromolar trigon is very common, or what is the mechanism of action? When there can be a trismus? So trismus is not a very common feature. Yeah, there can be a coexistence submucous fibrosis, which might be there, where there could be a trismus. Apart from that, when the pterygoids are going to be involved from the tongue, posterior aspect. In that case, a patient can have a difficulty in mouth opening. Karnagaran sir, hello. Right. And you said margins are raised. We say margins either it is a defined or ill-defined. We say raised is about for the edges. Keep the basics strong. Okay. Margins can be defined or not defined. The edges can be raised or it could be everted, like that you can say. You can't say margins are raised here, right?
Okay.
And deviation of the tongue to the ipsilateral side on protrusion of the tongue. What does it indicate to you?
It indicates involvement of the hypoglossal nerve, due to which there will be deviation and protruding tongue because of involvement of the muscles of the tongue, ma'am.
So you mean, so what are the muscles of the tongue? What are the extrinsic muscles and what are the intrinsic muscles?
Ma'am, extrinsic muscles of tongue, genioglossus, hyoglossus, palatoglossus, and styloglossus. Intrinsic muscles, superior and inferior longitudinal muscle, transverse and vertical muscle of tongue.
Okay. So what is the significance of this muscle, especially your genioglossus?
Ma'am, genioglossus helps in retraction of the protrusion of the tongue, ma'am. Is usually in
Okay.
protrusion of the tongue, that's preventing the airway obstruction. It is also known as safety
Okay.
muscle.
If you have the involvement of the genioglossus muscle, in that case, what is going to be happening?
Protrusion of the tongue will be difficult, ma'am. And
Okay.
there will be.
Okay, go ahead.
It will lead to obstruction of the passage.
Right. Next slide, please. So palpation, your findings to confirm. Where did you look for warmth?
Over
You look
the
for
answer,
warmth within the oral cavity. We don't look for that warmth there, right? If at all you want to look for warmth around the facial area. Otherwise, here I don't think you look for warmth in the ulcer. It is not
Okay.
required there, right?
Okay.
And there is no. How do you know that there is a floor of the mouth and was not involved?
By palpation, if the induration is extending it to the floor of the mouth, it means the tumor has invaded the floor of the mouth.
Okay. Any other way?
Ma'am,
You can catch hold of a tongue and ask her to make the act of swallowing. So it will tend to pull inwards. Okay, that means the floor of the mouth is not stuck there. Okay, if it is stuck, it will not go back.
Okay.
Right.
Yes,
And you say it doesn't bleed on touch for you, right? Next slide, please. We went on to this one. Okay. What about the dental formula? Where have you mentioned? Here, in local examination.
General examination.
அங்கே சொல்லிட்டீங்களா? Okay, 2, 1, 2, 3 and 2, 1, 2, 3. Right. I think you can say when you are doing the oral cavity examination, you can say about this. And you can also talk about the what are the movements which was restricted. Just generally said movements restricted, your tongue is restricted. You not mention which is the movement which is getting restricted here. Which movement is restricted?
With protrusion, there is a deviation of the tongue towards the ipsilateral side, ma'am. All of the movements are
right. Regarding the ulcer, you said whether it crosses the midline or not.
No, ma'am, it doesn't cross the midline.
The induration also doesn't cross the midline.
No, ma'am, it doesn't cross the midline.
It is confined only towards the
left side lateral
of the left side, left lateral aspect. Right. Fine. So when you do a clinical examination, the things you are supposed to look for would be first look for the mouth opening, check for the mobility of the tongue, and anteriorly you see whether from the tongue whether it is going to involve other structures anteriorly coming towards the closer to the lip area on the inner aspect, and posteriorly whether it is going to involve the base of the tongue. And when you are on medially, you see whether it is crossing the midline. On laterally, you can try to see whether the floor of the mouth is going to be involved. If at all the floor of the mouth is going to be involved, then check whether the mandible is also getting involved. And posteriorly, you see whether the anterior facial pillar of the tonsil and the tonsil is getting involved. So these are the areas which you are supposed to examine when you are going to do this examination. Right. And this patient has got a node in the neck. Right. What stage your patient belongs to clinically?
Ma'am, clinically, T3 N2, N2 AMX. T3 N2, ma'am.
T3 N2. Why do you say it's N2?
Ma'am, the size of the lymph node is more than 3 centimeter. Ipsilateral single lymph node more than 3 centimeter, ma'am. The N2 means 3 to 6 centimeter ipsilateral single lymph node. N2A.
Okay.
That's N2B is multiple ipsilateral nodes 3 to 6 centimeter. Bilateral or contralateral lymph node 3 to 6 centimeter is N2C.
So this patient has got only unilateral nodal involvement. So it's a T3 N2 disease.
Yes, ma'am.
Okay, and MX clinically or metastasis is not evaluated. So belonging to what stage grouping?
Huh? Stage, ma'am.
Stage grouping.
Ma'am,
Yeah.
4A, ma'am. Stage 4A.
Okay. So how do you want to proceed in this patient? Any differential diagnosis for this case? When you should say there are no differential diagnosis, that's all. Okay. Right. If at all there is any swelling or a small trivial ulcer kind of a thing. In that case, what are the possibilities which can be considered for an oral cavity differential diagnosis? A smaller swelling, a small ulcer kind of a thing.
Ma'am, maybe
the pyogenic granuloma.
Yes, ma'am.
Then what are the swellings which can occur in the oral cavity? What?
TB ulcers, syphilitic ulcers.
How many tuberculous ulcers have you seen in the past 3 years, man? It's not a very common entity, right? Talk about what we see commonly, right? Then
Aphthous ulcers, small ulcers, multiple ulcers, painful.
Okay, right. Accepted. Then some rare conditions, something, any ulcerated lesion, something like that. Sometimes you can even have some minor salivary gland tumors, which can be present in the neck, in the oral cavity. Okay. Right. Sometimes you can have a sarcoma which can be present in the tongue, like a rhabdomyosarcoma, or sometimes there could be a lymphoma which can be metastasizing into the tongue, right? Or there could be an AV malformation, like an hemangioma which can be sitting in the tongue. So all those things can be appearing as some growth lesions which can be present there. So these differential diagnoses should be considered, right? Whenever you have a lesion in the tongue, because always all the lesions are not going to be ulcerative. Sometimes there might be an infiltrative lesion which will be appearing as a thickened one, right? In that case, these possibilities has to be considered. Right. Coming on to how do you plan to proceed in this case?
Excuse me. Can I ask 1 or 2 questions?
Please, sir.
What is N3A and N3B?
Sir, N3A is external nodal extension is absent in N3A, and in N3B external nodal extension will be present, sir.
In AJCC8,
Yes, sir.
in a patient with HPV positive,
Yes, sir.
HPV positive. Am I right?
Yes.
What is the role of N3B?
I don't know.
Don't know. There is no N3B in patients with HPV positive. Okay.
Okay, sir.
What are all the significant features of HPV positive patients with the CA-tongue?
Sir,
Or
actually
oropharyngeal
better
malignancies?
prognosis.
Pardon?
Sir, they have a better prognosis, sir. Because of
Yeah, young patients are affected.
Yes, sir, less than,
better prognosis.
Antivirals can be given for HPV.
What is the mutation that is common in HPV? Overexpression of which gene? No. What other changes are there in AJCC8 in regarding HPV positive oral malignancies? So there is no TIS in HPV positive patients. There is no TIS in HPV positive patients, and there is no extranodal extension included in these patients, and they have got better prognosis since they are young patients. They are not related to tobacco. Okay. Yes. Doctor, please proceed, Anandi.
Okay, how do you want to confirm your diagnosis?
Ma'am, for confirmation, I will go for incisional biopsy.
Okay. What is this incisional biopsy? Why not? What is the other form of biopsy like to take?
Edge wedge biopsy and a punch biopsy.
Okay. So how do you know that you have taken an adequate biopsy?
Ma'am, we have to take from the most suspicious part involving the normal tissue.
Okay. So what will happen when you take the normal tissue?
Sir, to compare whether there is dysplasia.
To compare whether there is dysplasia. Then anything more? See, when you take, the question is, how do you know that you have taken the normal tissue and also the abnormal one? If you're going to take only the sloughed out material, it won't bleed. Okay, when you take a good adequate punch or adequate thickness of the normal tissue, that area will bleed. If there is a bleed, definitely it indicates that you have taken an adequate sample. Okay, how do you control the bleeding in the tongue?
Ma'am, either we can fulgurate or
fulgurate.
Or
over the growth in fulgurate to diathermy.
Ma'am, with compressive, it will settle, ma'am, with the compression.
Yeah. See, if it's going to bleed from the normal area, you can take the simple suture with a cadget, you can take it. Or if it's still bleeding, then you can place an adrenal soap gauze over it and ask the patient to keep it.
Disconnected.
Yeah, you are audible.
Hello, ma'am.
You are audible.
I see. Ma'am, we can keep adrenal soaked gauze to stop the bleeding.
Kalayarasan, are you here?
Yes.
Am I there?
Yes, ma'am.
Ekda?
Yes, ma'am.
Madam, you are fine,
yes,
ma'am. You are
audible,
fine. Please go ahead. Again, I think she is lost.
See, Kalayarasan.
Yes, sir.
Can I ask one or two questions?
Yes, sir. Please, sir. Please go ahead.
See, if the lesion is present in the posterior 1/3 of the tongue, if the lesion, see, it is an hypothetical question. If the lesion is present in the posterior 1/3 of the tongue, how can you take a biopsy?
Sir, under anesthesia.
It's a simple common sense question.
Sir, using indirect
See, accessibility to that area is limited. So you can't do a incision biopsy that much easy as you think. Can't you think anything else, any type of biopsy?
Sir, smearing a swab we can take for cytology.
See, let me tell you, why don't you take a punch biopsy? Is it possible or not? Am I audible?
Yes, sir, audible, sir. Punch biopsy also is difficult to take.
The why punch biopsy is difficult? You are taking a punch biopsy from CA cervix, which is much more deeper and difficult, and you are taking a punch biopsy in a case of CA rectum. Why don't you take a punch biopsy from the posterior 1/3 of the tongue? Why is it that difficult?
Not easily accessible.
Am I right or wrong?
Sir.
No, it is not easily accessible for incision biopsy, not for punch biopsy. Have you ever done a punch biopsy?
Yes, sir.
You are practicing punch biopsy or not?
Yes, sir. Practicing.
Then you won't tell this answer. Okay.
Yes, sir.
Madam Anandi, is it
Yes.
audible for you?
So you have done the biopsy now, you have done the staging. So your patient belongs to stage 4A,
Yes, ma'am.
right? What kind of a metastatic workup you are doing?
Ma'am, we have to CCT neck and chest is needed, ma'am.
PET scan.
Hello, ma'am.
Yeah,
Ma'am, yes, ma'am. PET CT is needed.
in all cases or in your patient.
Ma'am, in advanced diseases, we may need PET CT.
What do you mean
If
by
you're going,
advanced disease?
see,
Stage 4B, 4A.
see, your patient has got a T3M2 disease, you said. Why you want a CECT neck and again a PET CT? Why you want to go for two investigations? Why can't you go for one single modality as a PET CECT, which should be helpful for evaluating the entire thing in one go, right?
Yes, ma'am.
But for pertaining to the tongue, you don't do any other investigation. You've not done anything.
Ma'am, MRI can be done to look for a neurovascular invasion.
அவரோட சிக்னல் ரொம்ப கம்மியா இருக்குன்னு நினைக்கிறேன்.
Hello,
என்னோட
ma'am.
கம்மியா இருக்கான்னு எனக்கு தெரியல. கலையரசன்.
He is all right, ma'am. Kalai, you cut down your video maybe if that is going to help you, or stop sharing your PPT.
நானும் cut down. Yeah, I also cut down the video.
Try, ma'am.
Is it okay now, ma'am?
Yeah, clear, ma'am. Any other investigation you like to do for the tongue?
Ma'am, MRI to look for neurovascular invasion and
Okay, what are the things you see in the
extent of the tumor can be seen and the neurovascular invasion can be seen.
Apart from that, anything else can be seen while doing the MRI? When you're going to take an MRI, will you be taking only for the tongue or it will include the neck also?
No, it will include the neck also, ma'am.
In that case, what are the other things you can see?
Ma'am, nodal involvement and the vessel in vascular involvement can be seen, ma'am. Carotid and interjugular vein involvement can be seen.
So the things which can be made out would be the size of the tumor you can pick up, the depth of the invasion you can pick up, and how far it is extending beyond the midline can be identified, whether it is involving the adjacent structures like the floor of the mouth or the posterior aspect of the tongue can be picked up, and also your mandibular involvement, if it is there, can be identified. And you can also pick up there is going to be an external extension in the lymph nodes. All these things can be picked up with an MRI. Right. Right. So having done this, what do you mean by depth of invasion?
Ma'am, depth of invasion is invasion of the tumor crossing the basal membrane, ma'am. If the depth of invasion is less than 5 mm, it is T1. If the depth of invasion is 5 to 10 mm, it is classified as T2. And if it is more than 10 mm, it is classified as a T3, ma'am. And if the depth of invasion is more than 4 mm, there is more chance of nodal metastasis.
Very good, right? So even in the presence of a clinically negative neck, when the depth of invasion is going to be more than 4 millimeter, then
you have
to go in for an elective nodal. Nodal dissection has to be done. Okay.
Yes,
Right. So what do you plan to do for your patient?
In this patient,
Dr. Kallai, why the PET is not a standard of care in any of the malignancies? What is the reason for that? Even for the oral malignancies, it is not the standard of care, isn't it? Why so?
stand up,
I'm asking that why the PET scan is not a standard of care
yes, sir.
for almost any malignancy.
It's not in routine protocol. Why?
The reason is that it gives so many false positive results or false negative, whatever you say that. That if somebody has got like somewhere, he had a fracture of the bone was there and that will pick up.
Okay.
So you may think it is a metastatic deposit, but it is not.
Yes, sir.
Apart from the cost of the investigation which is there, this will make the surgeon or the doctor puzzled that whether that is a metastatic deposit or not. So PET scan is mainly for the recurrent disease. If you when you're following these patients, like in the CA breast or any other malignancies, if you are suspecting the patient is having the recurrent disease is there, then you carry out the PET scan, but not as a first line investigation for the PET in a malignancy.
Okay.
Okay. So once the patient has the C of the tongue is there, MRI is the investigation of choice. Okay. You should carry out the MRI for these patients to find out that.
Okay, sir.
Okay. What is the biopsy report of your patient?
Sir, squamous cell carcinoma moderately differentiated, sir.
Okay. What other carcinomas can come in the tongue?
Sir, adenoid.
Yes.
Basiloid variant of
Yes.
carcinoma.
Right.
And sarcomas.
Yes.
And minor salivary gland tumors.
Right. Okay.
And
So the patient is a case of squamous cell carcinoma grade 2, isn't it?
Sir, yes, sir.
And the lymph nodes are
Clinically
positive.
positive.
Right.
Clinically.
Okay. So how you are going to treat your patient?
Sir, in this patient, there is no mandibular involvement, and hence I will proceed with hemiglossectomy and MRND, ipsilateral MRND. Sir.
What is commando's operation?
Sir, excision of the tumor along with the hemimandibulectomy and neck dissection, sir. MRND.
Right. And what is this MRND?
Sir, modified radical neck dissection.
So which type you are going to carry out?
Sir,
which
the
type
type
of MRND you are going to do?
Sir, in this patient, while discussing with the radiologist, they said there is a node encasing the internal jugular vein for about 180 degrees, sir. So I will proceed for one type 1, sir.
What
In
are the
this
different types of MRND?
So 1, 2, and 3. In
Yes.
a type 1, spinal accessory nerve will be preserved, and in a type 2, spinally accessory nerve and internal jugular vein will be preserved, and in type 3, spinal accessory nerve, internal jugular vein, and sternocleidomastoid muscle will be preserved, sir.
So in type 1, you save the spinal accessory nerve.
Yes, sir.
Okay. In 2, you save the internal jugular vein, and 3, you also save the sternocleidomastoid.
Yes, sir.
Okay. So in your patient, when the internal jugular vein is getting involved,
Yes, sir.
so what type of the MRND you are going to do?
So in type 1, sir.
No, once a main structure is getting involved, it will be better to go for a classical one, isn't it?
Okay, sir.
Any of the structures, if it is getting involved in that, it will be better that you go for the classical radical neck dissection.
Okay.
Now, what are the things you remove in the classical radical neck dissection?
Sir, level 1 to 6 lymph nodes along with sternocleidomastoid, internal jugular vein and external jugular vein, spinal accessory nerve, and cervical plexus, and submandibular gland and the lower pole of the parotid gland.
So if you are going to do a hemiglossectomy in this patient, are you going to repair the tongue or you are going to do
Sir,
a primary closure of it?
Sir, we have to go for a reconstruction, sir, using free radial flaps from the forearm radial.
So do you think if the hemiglossectomy is done, it really requires a repair of that?
Sir, if there is a loss of more than 1/3 of the tissue of the tongue, it needs a reconstruction. Sir.
Okay. And how you are going to repair that?
Sir, using free radial forearm flaps.
Okay. Can you use any other flaps apart from the free flap?
Sir, if the defects are large, we can use a pectoralis major flap and
so if you use this pectoralis major flap, what is the problem?
don't know, sir.
No, there may be hairs may be there.
Okay.
So you choose that non-hairy area of that flap goes inside the oral cavity.
Okay, sir.
Okay. All right. So for doing the block dissection,
Yes,
which incision you are going to give?
Sir, McAfee incision and modified crane, Martin incision.
What is the difference between all these incisions?
Sir, modified crane, the incision is Y-shaped, extending along the mandible, and vertical incision extending towards the midline of the clavicle is used, and in McAfee, 2 linear incisions were used, and Martin is double Y incision.
So the 2 flaps, 3 flaps, 4 flaps, and a bris flap.
Yes, sir.
So these are the basic. So you can raise the 2 flaps, you can raise the 3 flaps, you can raise the 4 flaps, like the Hayes Martin, which is there. And then you can use the bris type of the incision, especially like the radiated neck is there. You will leave the central portion of the skin intact.
Yes, sir.
Okay. Now, what
Regarding the
complication?
primary, what is the amount of clearance you want to give?
1 centimeter. 1 centimeter of clearance should be.
Okay, when will you consider to be the margin is involved?
Pathologically.
Yeah, pathologically, when will you say the margins are involved?
There is a lymphomuscular invasion.
When you have a clearance of less than a millimeter,
Yes, ma'am.
okay, then you have to consider that these patients can land up with your recurrence. There's a higher chance of recurrence. These are called as an involved margins.
Yes, ma'am.
Okay. What do you mean by molecular margin?
Is it incon?
So try to look for any P53 or HER2 new the free margin. And these are going to be positive. It results in a recurrence, or there can be a second primary at that same stage. But nowadays we don't do these things. But these are all recent things which are coming up.
Okay.
Okay. If your patient is doesn't have any nodal disease, it is going to be an N0 disease, how are you going to manage?
In this case, we have to do excision of the tumor along with the supraomohyoid dissection over the ipsilateral side.
What are the nodes which are removed in a supraomohyoid neck dissection?
level 1, 2, and 3 lymph nodes.
It's usually preferable to go in up to 4th level, right? Extended supraomohyoid neck dissection for a tongue lesion, right? What do you mean by skip metastasis?
In a CA tongue, the lymph node metastasis is via the embolization of the tumor cells rather than the permeation. That's why the cancer cells will be laden in the distant lymph node, even without the occult metastasis in the sentinel nodes, ma'am. And there will be decussation of lymphatic fibers in the tongue that will lead to metastasis in contralateral side also, ma'am.
So skip metastasis early diseases, it means that if you're going to have a disease which are going to be present not in the first level, where you expect the nodal disease to be there and it's going beyond that. For example, if level 1 is not there and level 2 is not there and level 3 is also not there, but level 4 nodes are going to be positive, then this kind of a disease is considered to be as a skip metastasis, right? But if for example, if 1 is present, 2 and 3 are not there, and 4 is present, that doesn't come under skip metastasis. All the 3 levels should not be there.
Yes.
Then only call it as a skip metastatic lesion. Okay, what is the role of sentinel lymph node biopsy in a clinically negative neck?
In this case, because of skip metastasis,
Not
it is
in this
not
case.
in a CA tongue.
Okay.
Skip metastasis is not significant.
The question was, what is the role of sentinel lymph node biopsy?
To assess the nodal occult nodal involvement, we can do sentinel lymph node.
With MRI, can't you estimate whether the nodes are involved or not? Can't you identify that?
Smaller occult metastasis. It's not audible.
With an MRI,
Yes, ma'am.
do you won't be able to estimate, identify whether the nodes are involved or not?
Smaller occult metastasis cannot be made out.
So when you have a suspicious lymph node on an MRI, then you go for a sentinel lymph node biopsy.
Okay.
Right? Or you can do an ultrasound guided FNEC of that, and then you can do a SNNB. Otherwise, what happens is when you're going to plan in for a sentinel lymph node biopsy, the time duration and other things are going to get dragged. Rather than going for a upfront surgery and along with the nodal dissection, the time and the cost factor would be better delineated, right?
Yes, ma'am.
So that's why sentinel lymph node is not that much practiced in a tongue disease.
Yes. Not audible. Not. Yes.
What are the adverse features you're supposed to look for post surgery in a nodal disease?
We have looked for involvement of the posterior tongue floor of the mouth and the retromolar trigon and the mandibular involvement, gingival involvement, and whether
adverse features in the biopsy, nodal biopsy. Okay, go ahead.
Lymphovascular invasion. We have to look for lymphovascular grade of the tumor and whether the lymph node involvement and number of lymph node involvement. If there is lymphovascular invasion and more than 2 nodes are positive and high grade tumor, we have to go for adjuvant radiotherapy.
Okay.
And extranodal extension, if there is extranodal extension in the lymph node involvement, in that cases also we have to go for adjuvant radiotherapy.
What is the role of neoadjuvant chemotherapy in a tongue disease?
If the patient is unfit for surgery and in a morbid performance status is poor, we can go for a neoadjuvant chemotherapy and the palliative or team.
You mean to say an operable patient, but the patient is not generally fit. That case, you want to go for a NACT.
Advanced diseases in advanced diseases.
Apart from that, any other indication? When you have a lesion in the tongue, it is extending below up to the hyoid bone, right? Or it is going into the vallicula, or it is reaching the temporal fossa, inferior temporal fossa, or there's going to be any infiltration. In these cases, you go in for a neoadjuvant chemotherapy.
Yes, ma'am.
Okay.
Kalai, you switch on your video,
So
ma.
Yes, sir.
Right. What is carotid blowout?
Sir, post neck dissection, if the carotid is completely stripped off, it will stripped off. It will let to blow out of the carotids. That's a complicated.
So what are the ways to prevent the carotid blowout?
The carotid should not be completely stripped off, and it should be adequately covered with skin. Sir. Flap.
No. Like if you're doing an inguinal block dissection,
Yes.
and the femoral femoral vessels are exposed, can you cover it with some muscle?
Yes, sir. Sartorius, gracilis can be used, sir.
No, sartorius is okay. No?
Sartorius.
You said the sartorius. Sartorius is okay. No? You cover it with the sartorius. But in the neck, if you are doing the carotid, can you cover it with some muscle?
Levator scapula can be used.
Levator scapula can be used. Yes. That is the muscle which can be brought in front and cover over the carotid vessels. Okay. Second is that you should try to avoid any infection there and the flap necrosis.
Yes, sir.
And that is why when you are doing the Hayes-Martin operation,
Yes,
the 4 angles which fall there, they should not fall over the carotid sheath.
yes, sir.
They should be away from the carotid sheath. Okay,
Yes,
because if the flap necrosis is there, there is chance of infection is there, and that can lead to the carotid blowout.
Yes, sir.
What is the difference between a radical neck dissection on the right side and the left side?
Sir, while doing both sides simultaneously, we have to prevent. We like to preserve at least one internal jugular vein.
No. What structure you will get extra on one side, left side or right side?
Some glistening structure. On the left side.
You have done the radical neck dissection and the white fluid started coming out.
Sir, thymic ducts over the left side.
Thymic.
Thoracic, sir. Thoracic
duct, yes. So thoracic duct is on the left side. No?
Yes, sir.
So you have to take extra care when you are doing the lower dissection there, that
Yes,
you
sir.
do not damage the thoracic duct.
Yes, sir.
Okay, madam, if you want to anything, or Dr. Kanagal, can we stop here?
Yes, sir. Yes, sir. Any questions from your side, Dr. Kalai, you want to clarify from the faculty?
Sir, no, sir.
I think
No.
faculty, any comments? Can we call a close?
Yeah, I think so, yeah.
Thank you.
Thank you, madam.
Thank you, sir. Adil, sir, thank you very much. Learned lot
Thank
of
you for
points.
joining today. Kalai, thank you for joining, ma. I kindly
you.
give my regards to Professor Vasan for permitting you to present in this forum. Karnakaran sir, thank you very much.
Thank you.